Yeah, yeah. So sure. If she is, she can stand up with flash. It's okay. I'm actually on the city. I'm able to get on the city.
That, okay, all right, cool. Yeah, that was the fun.
I've asked her to bring and I don't know. I don't know why, but she's going to bring here. That's more science. So, my name or no. And then come back to place it as a Monday.
Yes. Hey, do we want people to approach the microphone to ask questions, or are we gonna take the microphone to Bill?
It might be easier to walk this, which that makes like you walk.
Yeah, we planned it. Okay.
And last time. And it's.
I was trying to scramble. Yes, I can do it there. I can take it back.
So you're streaming.
Yeah, we have it, she's gonna stream it on Facebook. Okay. I'm doing Google Meets in case anybody wants to actively join. Okay. And, so it can work out. Yes. Yes.
So I should have moved too much. I should sit there.
Milkshake.
Okay. So it worked out. I didn't know that. Okay. So you run that Facebook. So it's like not.
I can fit.
I'll just try to stay there. I'll start. I'll try to stop.
Okay. But if you can move, I can.
A little bit. All right. Thanks. This is about live. I like that. Definitely say you're really facility. Okay. So, you got Facebook Live. Yes. Yeah. I was so I don't even see that right. I'm like, good catch. Yeah. Yeah.
We keep forgetting that. Yeah. I just That's not gonna work. Well, we are eating, I did today.
You said that necessary should. We could really enhance. So a moment ago, there's someone's first slide that has all of the partners on it. Did he say not to have that up? Because I guess I'm saying something. If I have it up while I'm eating myself. Yeah. Oh, cool. It's at least one more time. Yeah, I got it. I started over the school. Hey, how are you?
Probably.
Sure.
Yeah, there's a paper that's on the chair there. It's that combination.
Yes. Yeah, I just wanted to do the stand and overhead speakers. Which would have been close to the back. Probably how hard it's at, if you have to show.
I'm sure.
Yeah, it's like forehead James. Probably wasn't that automatically. So she goes, like, oh, but I didn't see it. That's like at the same time, I need to know about yeah.
Hello, good afternoon, everyone. Thank you for attending our public session. My name is James Corbett. I'm principal of Initium Health, and I am supporting the efforts to build a regional behavioral health center here. We're going to begin with opening comments from your mayor of Clovis, Mayor Mike Morris.
Thank you, James. Appreciate that. And good afternoon, everyone. I believe, in addition to opening comments, I have the privilege of leading us in honoring our flags. And so if you would stand with me, in fact, I'll offer a word of prayer and then we'll honor our flags. If you're a praying person, pray with me. Our Father in heaven, thank you for the blessings that you give us each day. Thank you for the amazing regional partnership work that is underway to bring behavioral health care services closer to home to Eastern New Mexicans. And Lord, we pray to bless our gathering here today and all of the information shared would be profitable and good for use. I ask these things in the name of Jesus. Amen. Join me in the pledge to our flag. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. I salute the flag of the state of New Mexico, the seated symbol of every Christian among united cultures. Thank you. And once again, good afternoon. I'm Mayor Mike. If we haven't had the chance to meet, if you've traveled in from out of town, welcome to Clovis. If you're viewing online, we welcome you and thank you for your participation in this information session, this public meeting where you're going to have the opportunity to receive a comprehensive update on what has shaped up to be an incredibly remarkable regional partnership work. As I mentioned in my prayer, the work is to bring behavioral health care services closer to home here in Eastern New Mexico. I want to recognize our partners in this work, leading the way in this work over the last couple of years now, 2+ years, in no particular order, but you have them on the screen there. Union County, Curry County, Clay County, Roosevelt County, Village of Fort Sumner, Portales, Clovis. Boy, I lost myself. You see all of the partners on the screen there. We also have Eastern New Mexico University and Clovis Community College. Cannon Air Force Base has participated. This has been truly remarkable. And for the most part, led with the support of the elected bodies, but really led by our city and county managers who have kept this moving and worked very closely with Initium. And so certainly want to thank Initium for their partnership and for creating this opportunity here today for this update. Want to thank our other stakeholders. We want to thank our federal delegates, which are supportive of this. Ms. Constance Williams, representing Senator Lujan, is here. We thank our other federal delegates as well as our state. In the update today, you're going to hear that the state of New Mexico, specifically from the governor's capital, has invested $10 million in this work to date. And so certainly appreciate the state's support and partnership. I want to thank and recognize the work of providers who are currently providing behavioral health care services in eastern New Mexico, and just simply say thank you for that work. As for those of us who did not have an intimate awareness of those needs and of the challenges in the work until this feasibility study was completed, our appreciation for your work has grown. And so thank you. Thank you for that work that you're doing. We see you, we see your efforts, and we see the pain and suffering in our communities, and we thank you for standing in the gap. I want to thank the public who has come out in person or who may be viewing online. This afternoon, you're going to get, as I said, a comprehensive update on a remarkable regional partnership collaborative project. A feasibility study has been completed, which resulted in a proposed plan, which you'll hear about this afternoon. Partnership support from many different directions and levels, and even a purchase of land. You're going to get a real-time progress report on what's happening with the project, exactly where we're at, and what it is believed is possible to be completed in the very near future. But before we get to all of that, I want to challenge us all. I'm speaking to myself as much as anyone here. We have a tendency, I think, as folks struggling with our own personal lives and our own work and whatnot, to come around a big issue and sometimes catch ourselves maybe in negative mindsets or solving for no. I want to just encourage everyone to be committed to optimism, not just this afternoon, but always and going forward around this project and everything. You know, it's an optimistic mindset is what allows me to keep going and the rest of you as well. And it's what's allowing us to get a lot of great things done in Clovis. And of course, being a part of this project is one of those things. So let's be committed to optimism. Optimism isn't just simply hoping something good happens, right? Optimism is a confident hope that we can have because we can reasonably expect good things to happen because we're doing hard work and good work. And although we see the obstacles, we believe that they can be overcome. So let's be committed to optimism. Also, partnership. I've already mentioned just in the last couple of moments about this is a story of partnerships, but at the city of Clovis, and I suspect that every other one of these entities, things get done by way of partnerships. No one gets good things and big things done on their own. And so we're grateful for the partnerships that have resulted from all of this. And I challenge us all today to remain committed to those partnerships. And it's sharing the risk together, shouldering the burden and the work together. And one day we'll be sharing the wins and the positive outcomes that come out of this collaboration. And the great part is that more and more Eastern New Mexicans will be able to reach their full potential. So let's be committed to optimism. Let's be committed to the partnerships. And thirdly and lastly, I just want to say, let's go ahead and make it personal, okay? Because it is personal. We're talking about our neighbors, our fellow New Mexicans, our community members, our literal next door neighbors, sometimes members of our family, people that we know, people in our communities that are struggling with substance use disorder or other behavioral health issues. And this work matters because it's going to improve lives of Eastern New Mexicans. And because Clovis isn't just any old community, it's mine and it's yours. Tucumcari, the same, Fort Sumner, Fort Tawas. These are our communities. These are our friends and neighbors. These are the residents of our community. So we should make the work personal and lean into it all the harder. Again, welcome. You're in for a great update as we work through the agenda this afternoon. Thank you for being here.
Thank you, Mayor Mike. Once again, I'm James Corbett, honored to be able to present to you today. Not my first time here, but we presented on the same topic in the Yam Theater about 2 years ago. I've come here now 15 different times over the last 3 years working on this project. I'm really excited today to talk to you about the progress we made. So as a start, Initium Health is a public benefit corporation. We're located in Denver, Colorado. We work with states and counties in 13 states now, always on the issue of behavioral health. In Palm Beach County, we have a project with them where we help them do a feasibility study, and they're off and running doing their building. Did something similar in Santa Monica and working on this project, I said, for over 3 years now. My background is I have a law degree and a master's of divinity, so a little bit of an odd background, and I think this work for me is more of a calling than a career. And I do believe that there's a kind of moral imperative to make sure those who are vulnerable, those with behavioral health needs, get their needs met. I come here today with Brian Friends. He's my partner on this. Brian actually leads a facility in northern Colorado called Larimer. And when he's got a lot of national acclaim in this space, I'll let him talk more about it. We brought a lot of the people from Palm Beach up, a contingency of 7 people to see his facility, to see how it's built. They too are in partnership of counties from around Colorado that came together and put their funds together to build a facility. And since he's living it day to day, I thought he would be a valuable resource to ask questions to as well. Here's the agenda for today. We're going to talk about crisis care and the crisis system transformation that's happening really around the country. We're going to talk about a regional crisis center facility. And then we're going to talk a little bit about workforce development, because one thing that's very clear from looking at this around the country is that if you're going to build a facility, particularly in smaller rural communities, you got to also build the workforce to staff that facility. So we've been thinking about that from the beginning. And then Brian's going to take it over to talk about the funding and financial projections. And we're going to give you an opportunity for Q&A as well. So I think I'll go maybe 25, 30 minutes and then open it up for questions and answers. And we'll stay until we're complete. Or at least I will. So this is the reason we're here in many respects. In 2017, Nathaniel Jouet, then a 16-year-old boy with medical mental health needs, came and shot Clovis Library. He killed 2 librarians, shot a young kid, shot this woman pictured here. And the reason I want to start with a kind of stark reminder is that I think that at times it's easy to think of these problems happening in big cities and outside of your community. But these problems are right here in your community, and this type of facility is put in place for people who have immediate need, people who are in crisis. So they don't continue to cycle on our streets. So they don't continue to cycle into our emergency room departments and into our prisons, and instead get the care they need so they can be rehabilitated and brought back into society. The current model, sadly, that we see around the country is the hospital is the center of care. So people are walking into the hospital with their needs, police are bringing people in with behavioral health needs, mobile outreach is dropping people off, and it's kind of scattered and it's chaotic, and it's intended to be so. And the former dean or president of Clovis Community College tells a story of a nursing student who had some mental health challenges, and they said, you need to go get help. So she went to the emergency room. And then the dean said, I was confused. I saw her the next day and I said, how are you doing? Are you okay? She said, I guess so. I sat at the ER overnight and they discharged me, so I guess I'm okay. There wasn't a facility for her to go. She needed a place to go to get the care she needs. So that's what we're talking about today. And crisis care facilities are showing value around the country. So hopefully, who here has heard of 988? Raise your hand if you heard of 988. Okay, good, we're getting there. We're not all the way there yet, though. Still nationwide, only 30% of people are familiar with 988. 988 is a nationwide resource for mental health. Instead of calling 911, you can call, text, or chat 988. So I want everybody in this room to know about it. I want you to tell your friends. It rolled out over a year ago, but unlike 911, everybody knows about it. Young kids know what 911 is, I'm sure. But when you think about 988, every state gets a rollout on its own, and some states haven't rolled it out as widely as others. Some states have put a tax in place to roll it out, a small tax on the cell phone bill. This state did not do that. And I don't think necessarily you need to, but we as citizens should spread the word of a valuable resource that 988 is. And why is 988 so important? At times, 911 is not the right number to call. At times, it exacerbates the issue, sadly. So 988, you get 24/7 support, and someone answers the phone, and they're trained in de-escalation. Now, I want to be clear: if someone's homicidal, suicidal, with a gun, not the right time for 988. Let's call 911. They're trained for that. But 988 can be a valuable resource. Studies show that 80% of people who call 988 have their needs met without further intervention needed. 80%, particularly if you're calling early. When that is still needed, when help is still needed, we suspect and believe that a mobile crisis team at times can be more effective than the police department, or a police department with the mobile crisis team called a co-location or co-respondent model, where they both come to support the needs. And again, trained in de-escalation. You're talking a licensed social worker. You're talking people with lived experience who can help to de-escalate a situation instead of escalate it. And then lastly, when someone still needs a place to go, and people do need a place to go, we're talking about a crisis care facility. And that brings us together today. The key is I want everyone to see this not just as a building. I want us to see it as a crisis care transformation that this country desperately needs and has taken too long to get here. But we are in the midst around the country of a transformation from ER as a center of care, from a behavioral hospital to crisis care facilities. And I'm seeing small communities around the country step up and own these facilities and build them to support their citizens, their military, police department, and on. So the three things that are easy to remember as well, and this is federal guidelines: someone to call, 988, not 911, someone to respond, hopefully a mobile health crisis team, and then somewhere to go, which is a crisis stabilization facility. So in this work, my partner Kate Bailey, in the picture to the right, the only woman in this picture, was here a few weeks ago with the police departments. And they were talking about this mobile crisis team and getting in the weeds about the different responsibilities and how they could work together. This movement's happening around the country where plainclothes policemen are coming to de-escalate situations, not uniformed, and working in partnership with social workers and others to de-escalate. We also, as part of this project, as you'll see, we have a model where we have vans as part of this. We can pick up people who are struggling. So it doesn't have to be the policeman. And once again, we'll do it in partnership with the police in case there are some strong criminal issues that need to be addressed. So I've been talking about this a lot and doing these presentations over the last few months with all the different partner commissions that are in virtual and in person, and continuing to tell the same story that I'm telling today. And I've got a lot of questions from them, and I'm happy today to give you a chance to say your thoughts and answer your questions as well. Also getting a lot more publicity on this as this comes to fruition. We're trying to put it out in the newspapers. We'll be developing a website. We'll be doing a lot on social media. We want people to know this is coming. And we also want to, at the same time, raise awareness of the importance of 988 and the importance of crisis response. Here's a key piece of legislation that changed our thinking. As was mentioned by Mayor Morris, we did a feasibility study. And initially, we were thinking about a bigger facility. We were thinking about behavioral health facility because the laws in this country are kind of odd as it relates to crisis care. Many countries, you can only be in crisis care for 24 hours. Many states. Some states give you 72 hours. Neither one are enough. Why do we put a limit on the need for crisis care? People are individuals. Sometimes they need more time. This state passed a law that no one else in the country has passed, and it allows you to have care for 14 days in a crisis care facility. This was game changing and allowed this crisis care facility to be built and to be built in a way that can support the needs of your citizens. We are not the only ones in this state doing it. I would highlight that Doña County is reopening theirs. There's one in Santa Fe, and then I went to the one in Albuquerque, and they just built one and opened in June 14, 2024. So you already have 3 in your state, but as you can tell from the names of where these are, not close enough to you. And that's why we're talking about building one right here. I want to highlight that this is not just some kind of new idea that came out of the blue. There's currently 576 of these in 2023. This year alone, another 180 will be built, and we expect that number to be closer to 400 next year. So this is what's happening around the country. It's a new movement And it's a movement where you're seeing counties and cities take the responsibility. Sadly, hospitals don't get paid a lot to do this, so they're not rushing to build behavioral health facilities. If you were talking about orthopedics or dermatology, hospitals would be more interested in it. It's not their fault, it's the payment model makes it very hard. So you're seeing counties and states around the country move into that space because their citizens need this type of care. So what we're talking about here, and I am originally from New York, so I can see myself talking fast. So just raise your hand and say, slow down, New Yorker. I'll talk a little slower. I'm a Mets fan also. Any Mets fans here? It never goes over well. Okay, so inpatient care for mental health and substance use will be one of the facility services that will be in place. Intensive outpatient and partial hospitalization programs, and Brian will unpack these shortly. Outpatient care, including medications for opioid use disorder and crisis triage center for walk-in and law enforcement drop-offs. Your law enforcement will tell you sometimes they're driving patients 2-3 hours away to get to a facility, and when they get there, they say that bed is now taken. We want to keep the police in doing the work they should be doing, protecting yourselves and your properties, and not driving a lot to get someone outside of our city. And oh, by the way, people who have this need deserve to be treated in our community. If someone has a medical issue, cancer, for instance, we don't ship them way off unless it's very extreme. We care for them in the community where they can have that community support. This is very crucial for behavioral health as well. So this crisis care services will have short-term observation. Clients with individuals experiencing psychs and substance use issues can be met here. And again, it's really going to be a place where law enforcement can come and within 30 minutes, drop someone off and get back to the work they're doing. So I know my law enforcement colleagues could speak later about how support they are at this. And here's the location. I think you may know already. It's right across the street from the hospital in town. It's about 18 acres. We will be able to have ER transfers directly from the hospital, medication-assisted treatment, and we're pretty excited about the location. That land was purchased. So the key strategies are with behavioral health, you can't build it and just think you're going to be able to stay profitable. You have to make sure you have a strong partnership with law enforcement, where they know it's available. They know it's going to be an easy drop-off for them, where they know they can come and put their guns in a place that's locked. So as you build this, you bring in police and fire and others and make sure it works for them because they're part of our team, if you will. There's going to be both detox services and involuntary admissions. We'll be staffing a social work, peer workforce, and a lot of clinical partnerships, and it will be a collaboration between the whole community. I'm going to move to financial projections. So we believe it to be about 12,500 square feet. Right now, we released an operator RFP, meaning someone to operate this. We're in the process of hiring a project manager, and then we will follow that up with an RFP for both the architect and the contractor. So we're moving pretty quickly on this one. The estimated cost of the build approximately $8.5 million. The land costs around $425. And because these communities came together, the partnership came together, they were able to get $10 million from the state. And I can tell you that if it wasn't for the partnership coming together, it would have been hard to get. We know that the money goes to the larger populations. And from a population health perspective, you can understand that. You can say that, we want to put more money towards where there's more people and more need, but we don't want to do it at the expense of smaller communities. By partnering together, the Clovises, the Curry counties, the Quay, the village of Fort Sumner, you were able to come together. Because you came together, you got $10 million from the state. In addition, we have other funding sources. We got $2 million from the feds, from the Health Resources and Services Administration, and that's to do workforce development and mental health care coordination. We'll talk about that. We also got funding from insurance companies. They put $1.8 million. So you're seeing what behavioral health has to be cobbling together funds from a variety of different sources and then monitoring the patient mix and ensuring that it's in place in a way that can be sustainable. And although it's built in Clovis, make no mistake about it, it's built for those who have skin in the game, those who put their behavioral health opioid settlement funding dollars at stake. They're going to have contracted beds, and they're going to have beds that are sitting there for them to use if somebody needs to come from play, if somebody needs to come from the village of Fort Sumner. People who are in Albuquerque will not have contracted beds. There's no harm. We like Albuquerque residents as well. We want to make sure this facility is for the people in this community. So with that, we'll talk a few slides on the workforce development. We're really excited about this effort in partnership with our friends of the United Way who are in the back. So with this $2 million from the feds as part of this effort, we were able to expand local internships and opportunities for bachelor of social work students. This model is a lot lighter on physicians and a lot heavier on social workers. We have a Master's in Social Work degree program, which launches in the fall of 2024 with ENMU. In collaboration with Clovis Community College for Behavioral Health Science student path, and we are building the future workforce to be in this facility. Other aspects of this partnership is a new course, Introduction to Social Work and Human Services. We're launching new paid local internship opportunities for behavioral science students and a complementary site expansion for nurses. And then I want to highlight that in April of 2024, hopefully some of the young students here today were there, we had 80 students in a panel discussion talking about capacity to move into this workforce, and we are giving paid internships to move people into this field of work because we'll need them. This four-county behavioral health partnerships has been a pretty important partnership between United Way of Eastern New Mexico, and EPCOG. It's been important because of the importance of getting the workforce involved, and really in some of that post-discharge care coordination that's happening right now with hospitals in our community. There's a plug for them. You probably have some of the flyers already, but they have an event coming up on November 15th, 2024 at the Clovis Community College, a Resilience Rising Symposium for Behavioral Health Collaboration. So with that, I'm going to turn it back over to Brian. Brian's nationally respected in his work. He leads a facility that is a little larger than this, but a similar model right in northern Colorado. After Brian goes through his, we'll open it up for Q&A. I do have some cards that I'll hand out and pens if you want to write down some questions. I'll do that now while Brian's speaking. Thank you for your time.
All right. Thanks, James. Nice to be here. Nice to see all of you. It's exciting to be in another community that is buying into expanding their crisis continuum. I feel like it was only a couple years ago, I was in a community meeting in northern Colorado doing a similar community presentation talking about the needs of the community, the gaps, how can we fill the gaps. And it's been a journey for me. So I'm going to spend a few minutes just talking about what that looks like for us up in Larimer County, Colorado. And you know, every community has unique needs, unique challenges, but I think there are a lot of similarities in sort of the project that we endeavored on and what you all are tackling. And so we went through a similar process where we went through a community needs assessment to identify the gaps. We went out and then talked to the community about here's what the facility would do. Here are the services that we need to add to our community in order to fill those gaps. And then went towards designing the facility, and a couple of years later, now I'm running the facility. So I've been able to sort of serve on all the different perspectives from the beginning to the end where we opened the facility, and now I'm able to run the day-to-day operations of it and really see the lives every day that we impact by offering those services. So, and this is the overhead of the land that James and the mayor talked about for your facility. So your plot here looks like a great site. So again, unique challenges. In Larimer County, we also had 8 municipalities in the county that formed a collaborative and decided to tackle that as a regional issue. Went through a design RFP, operator RFP, all the same steps that you all are going through. And again, going out and doing a lot of community engagement, hearing from taxpayers and residents and individuals who were impacted by mental health and folks that the system had not served in the past, and they talked about how broken it was and what was needed for us to fix it. And yeah, we opened our facility December 2nd, 2023. And the services that we currently offer are, we have a 24/7 walk-in behavioral health urgent care, so a triage center. We have 23-hour observation crisis recliners, receiving chairs, and I'll show you what those look like in a couple slides here. We have a crisis stabilization unit, and we have a withdrawal management unit for substance use and detox needs. So we opened that in December 2nd, and my goodness, the impact that we've already had is incredible. So we have done over 5,000 crisis assessments just in the last almost 10 months, almost 2,000 admissions. And, you know, one of the big gaps and reasons that Larimer County and the municipalities and the collaborative wanted to do this was they wanted this center to be a diversion center. They wanted folks to be able to come and get one-stop crisis care, behavioral health care, and divert from higher costly services, law enforcement, EMS, emergency departments. And just in our first 10 months, our main emergency department in our municipality has seen a 15% decrease in behavioral health related emergency department visits because those folks are coming to our crisis triage centers. So just some of the design, again, as James mentioned, you're all going to put out an RFP for the design build process. And what that looked like for us, some of the elements that we really focused on and got feedback on was, you know, this idea of going from sickness to wellness, natural light, really removing the institutionalization and the institutional feel from our mental health system and creating an environment of recovery. So you can see we have our gym recreation area, and then to the right is our dedicated law enforcement EMS drop-off sally port. So we have a dedicated handoff area, knowing that our law enforcement partners are some of our biggest and best customers. This is another healthcare center in Oregon. Again, these crisis centers are gaining popularity because they're bringing subject matter expertise to the community to do behavioral health care and approaching it from a no wrong door philosophy. So what's proposed is 10 receiving recliners, again, up to 23-hour stabilization, and then 12 short-term beds, again, up to a 14-day stay. And as James said, that's unique. So in Colorado, we can only do a 7-day stay. So here in New Mexico, there's a lot of value in an additional 7 days of stabilization and recovery focus. So I put this slide in here, SAMHSA guidelines, which is the Substance Abuse Mental Health Services Administration, the federal entity that oversees mental health and substance use services for the country, really just to highlight that there are national standards out there of how to do crisis care, and what you all are proposing and what you all are committing to really sets you above the standard across the country. There are very few communities that are adhering to these standards. And so you should all be proud of the work that you're committing to and that you're doing and the impact you're going to have on your community members. All right, so for the math folks, we'll spend some time on the numbers and financial modeling to really talk about how do we make these services sustainable and long-lasting in our communities. So again, we talked about patient volumes. We talked about the need for really strong partnerships with our law enforcement EMS partners. These centers work because people have committed to bringing folks in crisis there as a no wrong door. So that is the philosophy. And so that's where the work has to happen. Committing with law enforcement, EMS, fire, emergency departments to make sure that the folks that are in need of crisis services go to that facility and that center and receive services. We will talk about Medicaid revenue. That is the largest payer source for behavioral health services across the country and crisis services. And then we'll talk about commercial payer and commercial insurance and how they've been slow to the behavioral health payer field. And we really, as communities, and we need to talk to our legislators and make sure that that the behavioral health, commercial insurance companies are really adhering to parity and paying for behavioral health services equally as physical health services. And so we'll talk about what that looks like and how that those funding sources eventually roll up into this service. So the pro forma, that's a lot of numbers to look at, but what I want you to focus on, so total NPSR up there is net patient service revenue. Really what we've built is a 5-year phase model. So as all healthcare facilities, you need to phase your approach and phase your services. And so you can see year 1 to year 5, you're looking at a substantial increase in patient revenue over that time. And on the next slide, we'll talk about why that is. You've got salaries and wages for the personnel, and I've got a staff here that I'll talk through. But really the thing to focus here is with this 5-year phase approach, you've got some upfront costs to get it up and running. And as we see more payers come to the table, as the operator creates stronger partnerships with the community, with law enforcement, EMS, with the stakeholders, you'll start to see increased volumes as patients start to be seen at the center. Word of mouth really does help. We had, when we opened on December 2nd, a story that I'll share is that probably within 20 minutes of opening our doors, we had a woman walk in, and she shared with our staff that she waited 2 years for us to open that facility for her to get services and get treatment. And she said, I've been watching the progress of this facility and the community engagement, and I really wanted to get my services here and start my recovery journey here. And that was within 20 minutes of us opening. So there's the numbers up here, but on the other end of these numbers are individual lives and families in impact. So you can see that by year 3, you're making up losses, and then in year 4, you're actually past the break-even point and generating additional revenue, essentially profit. So in healthcare, we talk about payer mix. So these are the sources of reimbursement for behavioral health services, the largest sources of reimbursement. So as I said, Medicaid is the biggest payer source for behavioral health services. So you can see factoring in 80% for Medicaid patients. Medicare is there a little bit and will steadily be there, a small percentage. As James talked about and I mentioned, commercial insurance companies are starting to see the value in paying for behavioral health services and the impact it has on the whole person and their ability to save other costs later with healthcare expenses because they're getting the behavioral health care that they need. So they're starting to come to the table more. Again, the operator of this facility will work with those payers and continue to get new contracts, and you can see an increase from 5% to 10% in year 5. And then uncompensated pool, what that means is there is no payer source for those individuals that don't have insurance. Maybe they have insurance, but they have high deductible plans that are underinsured. Insurance doesn't cover those services. And so you can see over time with that increase in commercial insurance, you see some of that uncompensated pool go down, and that helps us get to year 4, year 5, where we're breaking even, and now we're actually generating profit from the services. Just a summary of a staffing model. So these centers are staffed majority by clinical, medical staff, milieu staff, peer specialists. Who here has heard of a peer specialist? What that? Yeah, so folks with lived experience, lived mental health and substance use experience, who share that experience and connect with individuals when they're in crisis. And we've seen a ton of value in that work in our facility. We've got about 10 peer specialists in the facility, and they just have a bit of a magic sauce to connect with folks on a different level that somebody that's clinically trained and medically trained can't necessarily do. So just a quick overview of the timeline. So James mentioned this already. In phase one right now, the re-release of the operator RFP, the design build RFP going out soon, moving into design pre-construction, early 2025 through the mid, and then you're really, then it's really the fun stuff. So you're designing the facility, you're engaging with the community, you're getting excitement built across the community and the stakeholders. And then you're working towards go live, where construction's happening the latter part of 2025 and going live in 2026. So again, just a rough timeline with those RFPs coming out soon. Some major milestones again with the timeline that we just talked through. And with that, I think James and I will be ready to answer questions.
Yeah, we got a bunch of questions on cards. I also want to allow Rachel, is there a mic?
Yeah.
Okay, good. I want to allow Rachel from Cannon Air Force Base to say a few words, and also want Mr. Gallegos to ask a question to say a few words, if you don't mind me put on the spot. Please.
All right, I'll come up here. Hello, everyone. I'm Major Rachel Wiley. I'm the mental health flight commander at Cannon Air Force Base right down the road. Flight commander is basically a department chief. So within mental health, we have 3 clinics: the mental health clinic, the drug and alcohol abuse and prevention clinic, and then family advocacy. We're really excited for this project, the 27 Special Operations Medical Readiness group and squadrons within it. We're just really looking forward to this opportunity. The thousands of hours that we lose on travel for our command teams, for our patients, for non-medical attendees, and the cost to have our individuals go oftentimes to Texas, to Arizona. Sometimes we have facilities driving to pick up our patients, so they're driving 8 hours to pick someone up and then driving back. So having this in our neighborhood will be just amazing resource for our individuals, our active duty and their dependent spouses. It also allows for multidisciplinary team meetings. So if we're right here and our individuals are getting crisis support, we can go and see them and have treatment team meetings together with the providers there, as well as the command teams, their families, and just being able to have that multidisciplinary, holistic approach for their care will really help us. I think that was the primary points I had. Any questions for me, or should I hand it off?
Any questions for Rachel? I think I speak for us all when I say thank you for your service.
Mark Gallegos, I'm the Curry County Adult Detention Center administrator. As you're aware, we do have a crisis center, and that's the Curry County Adult Detention Center. I'm happy to say that right now that I'm happy that we're going to get this into our community, because right now we're seeing a rise of this as it continues to happen with the substance abuse. And I call it not dual diagnostic, I call it tri-diagnostic, because what we serve is the criminal conduct and criminal behavior. We serve the mental health portion of it. Just move away. Okay. So we have severe mental health, which we're about 65% of the facility is in that data. And then 8 out of 10 individuals that come into the jail are either under the influence or abused in the last 72 hours. We do have a medication assisted treatment program as we speak. Right now, currently inside the jail, we have to this date turned off. We have 48 individuals. I'll use my military voice. We have 48 individuals right now in the MAP program. So just having this program come into the community is going to take a lift off of the jail. And that's what we serve right now. So it's tough. It's strenuous on the staff, but we're happy to see that this is going to come to Clovis. And I encourage anybody, if you have any questions about the jail operations or anything like that, we're always extending tours as to what we're doing inside the jail. But we got a great slew of staff that run the jail there. But again, thank you for bringing this to the community. Thank you. I'm a Colorado native. So I was a CAC 3 back in the day in Colorado, which is a certified addictions counselor. So I understand what you're trying to do. So thank you.
And I joke about Mark. Thank you, Mark. So the pleasure of presenting to the Lubbock, Texas Commission on Friday.
I also quote Mark Aiellos because he's the first time I heard of him talking about the difference in criminal care and custody care. How many people he has in custody sitting in the prison because there's no place for them to go. So I use that quote often, so thank you. I'm going to answer some of the questions here. I think we're placing the mic. Thank you.
Brian, I'll turn some of this over to you. So first question I have is, often we have no transportation from inpatient facility back to their homes. You mentioned vans to pick up. Would that apply to discharge and drop off? I'm happy to say the answer is yes. This model now of using vans is actually now something you can bill for. Historically, you couldn't bill for it, but there's a new ability to bill for it now. So that is definitely part and parcel of this model, including bringing people back to their communities, Quay and other places. That's question one. Sure.
Will there be a detox as an alternative to jail or detention? And the answer is yes. So as part of the receiving recliners and the short-term beds, they'll be able to do withdrawal management within those beds in addition to crisis stabilization. And then will the judicial system be able to do court order treatment? I don't know the ins and outs of your criminal justice and legal system, but in Larimer County, we utilize that. The court orders, short-term certifications and holds, and those processed through our facility. So I would imagine that there's going to be some connection and ability to do court order treatment through that facility.
The next question is mine. Will the center be capable of taking minors? I think you saw, yes, we are having adolescent as well as adult, and it's very important to have that. Will the facility be free of cost to those without insurance? And what does a long-term funding operation cost look like? So the answer is yes to that. And this is where the business objectives have to be really thought through. It is still a business. We have chosen not to take a tax in this community to pay for it. In Brian's community, they did do a tax. They taxed those communities. We decided not to do that here. So we're going to have to make sure that we balance the needs of taking those who are uninsured. But we're also going to need to make sure we have some insured patients. So whoever operates this has to be very skillful. Again, orthopedics, you can put up a shingle and make a lot of money in the hips and knees. But if you're doing behavioral health, you don't get paid the same way. So you have to make difficult decisions at times.
How will this facility continue to support the people, agencies in our communities that are already doing a lot of behavioral health work? That's a great question. Behavioral health, it's a continuum of care, right? And so the services that we're talking about and highlighting in this center really are short-term stabilization. You do get 14 days, but there's only so much you can do with folks in a 14-day period and a 23-hour period. You really have to get those folks connected or reconnected to outpatient services, ancillary services, primary care services in order to treat the whole person. So I would imagine that this center is just one dot on the continuum of care in their community for behavioral health services and another resource to be able to utilize at that point in time of that person's crisis.
And we don't have personal hospitalization program. Very few intensive outpatient programs. Many of the IOPs that we use are virtual. from the other locations I mentioned in Texas, Maryland, and so on. So having the levels of treatment beyond outpatient care is massive change for us here.
And Rachel, one more follow comment if you can. So are currently some of your colleagues leaving this community to get care for mental health? Or they need it? So they're not able to get the care right now in the community. Another reason it's just no needed.
I'm gonna bring the mic down.
So it's see you.
But I prefer not.
Okay, well, just don't go too long.
My question is, or my comment was, we have right now 3 IOP programs that we know of locally. So I saw that mentioned on the slides that was maybe going to be an option with the facility. So that was kind of where that was my.
Yeah, I think because there's enough behavioral health patients for us all to solve them, and we want to put implications. So if there's things that we're missing, but we'll have a lot of these sessions, as Brian said. How many tours did you do before you opened? Probably over 100. So there'll be lots of time from the beginning, design, concept, all the way to the opening to be a part of it. Brian, do you want to take the clinical question?
Can you talk more about the clinical partnerships? What exactly does this mean? What are you hoping to have partnerships with? Maybe this has to do with the workforce development work that's happening. Do you want to talk about I don't know the specifics of sort of the clinical partnerships, but I think it does connect back to the other question around, how are you going to help connect people back with their existing clinical resources in the community? Again, I think, to James's point, it's not a scarcity model. And I think the center can certainly, again, focused on a few different areas of crisis stabilization and, taking an agnostic sort of approach of, look, we want what's best for that client and that patient. So if that client and that patient came from an outpatient provider and is in crisis and we're able to stabilize and do some care coordination, we want to connect back with that provider and get that person back to their home-based care or their virtual care, and not uproot that system for that, right? So again, this center is one area on that continuum of care, but the goal is to have that person leave in a better position and well connected to resources to be successful after the crisis. So I don't know if I'm answering that as well as I could. There's a follow-up. What is the social work pipeline? Are you allowing LMHCs, LPCCs? Is there any support for the Master Counseling Program at ENMU? Do you have any more info on the ENMU partnerships?
Yeah, I think those partnerships are emerging, and I think that both Clovis Community College and ENMU have been at the table with us. We meet once a month, going on 3 years now, and the fact that we met together meant that this program could be developed. And I think there's opportunities to expand it even further. I don't want to speak on behalf of the university, but I know we do now have a social work program that wasn't in place. And I know that we now are amplifying the nursing capacity. And again, this model is different from the hospitals. There'll be a lot more social workers, peer recovery specialists, nurses, and there will be obviously psychiatrists, but the medical model is not the lead here. It's more of a collaboration model that is led by nurses and social workers. Good question.
So that was my question.
Okay, good. Thank you.
I was asking you, I noticed that you only had social workers, not like masters level counselors.
Yeah, so I saw that.
Sorry.
Yeah, so I think there's more opportunities there. And obviously, as you know, when you kind of start new programs, it's way beyond my pay grade. They work with the state, they get the approval, they got new funding to start this program. But I think that's step one. We still have a couple of years before this is open, and we need to keep going on those partnerships. I'm going to answer the next question. Will clients be allowed to come and go as they please, discharge and readmitted quickly? How will this be regulated with our revolving door clients? So, well, that's the question. Somebody very, it's a very knowledgeable group over there. Yeah, but sadly, we have what's called frequent utilizers, some call them frequent users, and places like Denver are studying it. They study the top 600 people in Denver, and they cost upwards of $10 million. Those 600 people, because they cycle out of the prison into the ER and the social services. So I think as part of this model, don't know if you're doing that, Brian, but as part of this model, we will be studying and working with those who are the kind of frequent users, and they need care coordination. I don't know if I highlighted it enough. So we've got this someone to call, someone to respond, someplace to go. But those wraparound services are crucial. Those community-based settings. In Florida, they use a model called People, Place, and Purpose. And they built that in partnership with United Way and others to support people who are going to keep coming in and out. And then there's a living room model. So a living room model allows someone to walk in and get the care they need in that moment. They can come there during the day and they can leave. I visited the model in Albuquerque, and they have a great model where people were there coming and going, and they were coming daily as much as they needed. There was a facility set aside for those. So I want to open it back up to questions from the audience or comments. Okay, a couple more. Here we go.
What obstacles are current crisis care centers facing? Post COVID, we saw mental health crisis just sort of be exacerbated, right? There was a lot more anxiety and stress on everybody in their personal lives. So we've certainly seen an uptick in mental health crisis across the country. Workforce, we talked a lot about workforce tonight, finding the right type of professionals, the right licensed people to do the work with state regulations, things like that. Aging out, workforce is a challenge, but the workforce stuff that you all have partnerships with really puts you ahead of the game. I mean, you've got some great workforce development stuff already in the pipeline, and that's huge to be able to reach down into your school system, into your community colleges. So you already have a leg up in that. And then it says, are any of the obstacles financial based? Of course, right? I mean, we talked about parity. Behavioral health services historically just haven't been compensated, reimbursed at the same level that physical health services have, but we've seen a massive shift in funding towards behavioral health. Again, since 2020, you've got opioid settlement dollars that are really coming into communities as a long-term investment. So yeah, there's funding challenges, but in my experience and what we've been doing in Northern Colorado in the modeling and the center that you're all proposing, like these centers are sustainable. They're financially sustainable. You just gotta make sure you leave that door open for patients in the region to come use it. So.
And the final question before I open it up for more comments is, will the facility be available to our border towns? Farwell, I think it says, and Millshoot. Okay. So this is a complicated question. I think that the opioid settlement funding, I want to make sure everybody knows, second largest federal settlement in the history of the country. Number one was tobacco. Number two is opioid settlement funding. Many communities around the country get funding for the next 15 years. The 8 communities that we talked about have decided to partner and put their opioid settlement funding together to build this facility. Even though it's in Clovis, it's a partnership. So they have skin in the game, so they have first right. So we're going to have contracted beds available for them to use. If there's available space, I think we're going to work with the other community towns. But I mean, part of this partnership was this model that their needs are met first. And then from further out, the further away, the less likely there'll be space available. But we knew that going in, which is why we're building something east of New Mexico. So with that, I'm opening it up for more comments. Comments, questions, concerns. I know it's on Shine Group. I've been here before. Oh, okay, good. Questions about it. Maybe you can state your name, what organization you represent. Please.
I was just wondering if you're going to be contracting with the Veterans Administration.
So this is an important question. So I think that there's a insurance from the Veterans Administration, and our hope is to be available for all payers. And we really want to make sure that we're supporting the military. So the answer is yes, we want to contract and get reimbursement for those services. But we want to make sure the Canada Air Force Base is well supported. Other questions? Okay, thank you.
I know phase one said 12 beds. How many beds are we anticipating, like, in total at the end?
So this is a open question, right? So we have to study this model. And if you would ask me this question before the law changed, I would look at the data and say, this is what we need. But without law change, what can happen is you have to leave them for 14 days. You can discharge them, readmit them. I'm talking 28 days. That's pretty close to 30 days. I see you shaking your head because 72 days, 72 hours doesn't work, 24 hours doesn't work. So this model might be that phase two might be a little different. It might be residential, might be less bad. So I'm not prepared to say it, but I want to speak a little bit about what you see in your model. Maybe just high level. Let's talk about the partnership with the University of Colorado Health System too. I think they want you to know about the importance of hospitals and how hospitals like this model.
So, our approach has been to keep it somewhat flexible. So we started again with, I think, 24 beds is what we started, and we have capacity to do 60. And we really decided to start small because we weren't sure. We never had a resource like that in our community. So we wanted to see how it would be utilized, what beds would fill up faster than others, where the need, what is law enforcement seeing, what are our communities asking for. We focus mostly on adult beds, but our urgent care serves adolescents, and our community has said we really need some adolescent beds, and so we wanted to keep the additional beds and future capacity expansion flexible based on the community needs. And I think the collaborative we all have regionally is super helpful to be able to inform that as a community and say, you know what, we did 12, but we're seeing this need now in year 2. Let's see if we can meet that. So James talked about partnerships with our hospital system. They partnered with us early on. Again, not a scarcity model. We see the same patients just in different systems at different points in time, and we really committed to just supporting each other and the services that we offer. So one example of that is we talked about needing to do some adolescent crisis beds in our facility, and our hospital system was in parallel working on expanding their psychiatric adolescent beds. Again, a different level of care than what we could offer because we are doing crisis stabilization. We're not a hospital. And so we worked with them and said, okay, if you're going to add this many psychiatric beds, we'll focus on these crisis level beds, which can be a step down or step up into. And again, trying to build that full continuum of care with the existing partners and resources that we have in the community.
So we'll open up for final questions. I'll walk on back here and not trip over the cord.
I want to ask you a question, I think just out of naivete. Can you explain the differentiation between an inpatient treatment stay versus a crisis triage treatment stay?
Well, you're the closer to clinical than me, so I'll let you take it on. I think inpatient stay versus crisis care, the differentiation between the two. Oh, an inpatient bed versus crisis care.
Sure. I mean, well, there's several differences. One glaring difference is length of stay, typically. So crisis is short term, it's stabilization, it's acute need, it's safety planning. And inpatient is longer term. So we're talking 30 days or longer for inpatient, higher cost services, because you've got more medical staff that you need to staff those units with. Again, they're typically with a hospital system, a larger system. There's larger overhead costs, but in terms of the patient care, again, on that continuum of care, you've got sort of crisis, which then can step to a higher level of care for inpatient or step down from inpatient into crisis. So, and every state is different. The regulations and the guidelines are a little different, but generally that's sort of the differences between triage and inpatient.
I'm just wondering because New Mexico with a 14-day stay, a 14-day stay in a crisis triage center is typically a longer stay than an inpatient facility would keep an individual. So there just seems to, in my mind, it's just a kind of a confusion, but maybe it's the medical model driven inpatient versus the behavioral health, social work, counseling driven crisis triage.
Yeah,
Yeah, that's a great, I wasn't aware that inpatient in New Mexico was typically shorter than 14 days, because in Colorado, it's usually 30 days or longer. And those resources are pretty scarce. And so yeah, that's a nuance that the operator and the community partners will need to, come together and talk through about how to utilize that resource with that nuance.
how's that? You're three at MHR, correct?
Yeah.
Okay, yeah. So definitely it'll be part of our dialogue from the beginning and making sure the nuances are understood. I will say from seeing in other communities, there's a real understanding that the crisis care facilities will decrease the need for inpatient care. Like most things, you catch people early in their disease burden. So what we're seeing is, surprisingly, even places like Los Angeles, who have historically said, we need inpatient beds. What we've seen there is they quietly, because they wanted to avoid NIMBY, their client line, they built crisis care facilities on their state hospital campuses. So that's how they got around it. And now the data shows that they don't need more inpatient beds. Sadly, what they need is a little bit of a different ideology at times around involuntary admissions. They haven't moved there aggressively enough, but we are going to accept involuntary in this unit.
Yeah, one last question on my card that didn't get answered. So in a community care model, what are the key performance indicators, measures to show the efficacy and effectiveness of the facility towards the community? I talked a little bit about this in our model that, that 15% reduction in behavioral-related emergency department visits, that's the goal, is to try and divert folks from our criminal justice system, from our higher cost first responder systems. We want our law enforcement officers, our EMS, and we want them in the field doing the work that they are trained to do, which is public safety. And we want folks getting crisis services from subject matter crisis experts, right? So that diversion, I think the trickier key performance with that is cost savings. That's sort of I think, every community looks at that a little bit differently, but there's certainly cost savings of an incarcerated bed day versus a crisis bed day versus a hospital bed day. Client satisfaction is a big key performance. If clients are coming out of that center with feedback that the facility doesn't serve them well, it's not welcoming, they're not getting good care. I think, again, this being a regional collaborative, every community that is invested in this probably is going to have their own unique sort of performance measures that they're going to measure and want to highlight and look at with the operator. Are folks getting better? Are folks accessing outpatient services more regularly? Are they getting a follow-up appointment from discharging from crisis care? I mean, there's a lot of ways to sort of measure the impact of a center like this. And again, I think every individual community is going to look at it a little bit differently.
So let's come to a close. I want to close with a kind of sad statistic. 71% of suicides occur after only less than 1 month from seeing a physician. So people go into care, they look for help, they don't have a place to go. And 71% of the suicides nationwide occur from that dynamic. And, we live in a suicide belt in Colorado, Idaho, and others, higher than national averages of suicide. And there's somebody who works in this space, one of the fastest growing suicide population is middle-aged white men. So in New Hampshire, we had a statewide campaign where a state with a state moniker, anybody know what's on the state license plate in New Hampshire? It says live free or die. Live free or die, and the Brit knows. So live free or die. So how do you help a middle-aged white man get help in a state defined by rugged individualism? I don't need help. I'm living free. So we came with a campaign in that state called Strong as Granite, or Strong or You, or Strong in New Hampshire. And granted, it's ubiquitous in that state, so we re-narrated this notion of getting help as a strong thing to do. That's part of what we need to do in this community. It has to be different, it has to be customized to what's important and what's relevant in Clovis. So that's why that's my bald head. But I have to say, man, part of what is the challenge is stigma. So the Surgeon General says stigma is a killer in our community. And there's a study that says that people wait 7 years after they know they have a problem to get the help they need. And a facility like this that's welcoming, that people can walk into, is a step in the right direction. So I'm thankful for the opportunity to present this to you today. I'll open it up for final comments. I have Erin back there who's gonna do a plug. And then I'm here to answer many more questions with the mic or without the mic.
Hi, everybody. I'm Erin Birch with United Way of Eastern New Mexico, and in partnership with EPCOG, we have a HRSA grant and fighting stigma, making services more accessible across our community, working on that pipeline. That's all part of our grant. And I strongly invite you to attend our symposium on November 15th. All of these topics are about lowering that stigma threshold, right? Getting rid of the barriers for people to reach out, recognize they have a problem, get help, and also give us all maybe some same language around helping our neighbors. So please join us on November 15th. Please take this back to your office, share with your friends and family. And as Mayor Mike said, this is personal. It is really personal. There is someone in your immediate circle for whom these services are critical. And unfortunately, you might not figure that out who that person is until it's too late. By supporting the whole environment of mental health and behavioral health services, we can really make a difference because it takes a better, stronger, more connected environment of mental and behavioral health services to do the lift that we're really looking to do. And the crisis care center that we're talking about is going to be a huge help and a huge asset. It doesn't in any way lessen the school counselors, the counselors in our mental health providers, just person on the street who maybe doesn't say that derogatory thing about that person who's got a substance use disorder or something to that effect. So please join us. If you have any questions, love to answer your questions.
Any final questions or comments, anyone? Last word, Mayor? Yeah, the first word, okay, not the last word. All right, thank you all for coming. There's cookies in the back, and I stand ready to answer your questions and partner in this very important effort. Thank you for your time.